So again, my name is Sarah Pointer, and I am the Clinical Director for the Illinois Prescription Monitoring Program. And we're going to talk about obtaining access to PMP data for overdose prevention in your community. So what is the Illinois Prescription Monitoring Program? It is the state-run electronic database that tracks the prescribing and dispensing of all controlled substances, as well as select drugs of interest and other health information for all patients in Illinois. The purpose of the program is to provide providers utilizing a patient's first name, last name, date of birth with a rolling 12-month prescription history to help assist with their clinical decision-making process. While a lot of PMPs are really rooted in law enforcement, Illinois is really focused on trying to be a clinical support tool for providers, giving them that information at the time that they're making those clinical decisions to assist, as I said, with that clinical decision-making process. So what are some of the benefits of PMP data? So why would it matter for an opioid fatality review? As you know, when we're thinking about opioid fatality review, we're really trying to answer how and why someone died and what could have been done differently to prevent that death. PMP data gives you that objective, time-stamped history of the patient's controlled substance prescribing and dispensing leading up to their death. It can help you answer questions like, was this patient on an opioid or an opioid benzo combination? Were there any gaps in care, or did they see multiple providers, multiple pharmacies? Was there any kind of abrupt discontinuation that would have contributed to the overdose death? Is there any opportunities were there opportunities that were missed that could have contributed to safer prescribing, perhaps providing naloxone, or referring a patient to treatment? While it's limited value at its face, PMP data is limited value alone. I think that used in combination with the other data sources available to review boards, such as the toxicology reports or the medical records or other data sources, it can help the boards, better look at those systems and identify those opportunities that can change outcomes moving forward. So what can the PMP data show you? Well, from a practical standpoint, PMP data helps fill in those gaps of the story that are often missing from the toxicology report alone. The toxicology report can tell you what was in the body at the time of death, but the PMP can help you identify what was happening in those months leading up to the death. For example, as I mentioned, reviewers can see whether someone had an active opioid prescription or possibly overlapping prescriptions. Were they receiving any kind of treatment for their opioid use disorder? Were they on any of those high-risk combinations like opioids with benzodiazepines, or any kind of sudden discontinuation of therapy that may have increased their risk? When this information is reviewed alongside those additional data sources, as mentioned, the medical records or EMS data, perhaps scene data, it strengthens the board's ability to identify those actionable prevention strategies, again, especially around prescribing practices or coordination of care, harm reduction access. Nationally, we know that PMP data is already being used for this purpose. It's already considered a valuable tool in overdose surveillance and prevention work. We know that there are other states currently using PMP data as part of their opioid fatality review to improve the identification of risk factors that aren't necessarily visible in the death certificate alone, such as those recent prescribing patterns or changes in treatment. The CDC and our federal partners consistently are emphasizing the importance of combining this PMP data with fatality review data to better inform those prevention strategies, especially focused on the safer prescribing and treatment access, or perhaps naloxone distribution. For local health departments, This means that you've already got this well-established tool to strengthen the impact of your recommendations. So we're excited to kind of figure out how we can move forward with making this happen. The first question that is always asked is, what is the authority for opioid fatality review boards to have access to PMP data? And we believe that Section 318 of the Illinois Controlled Substance Act, entitled Confidentiality of Information, provides this authority and allows for this type of data sharing. It states that public health administrators and their delegated analysts of a local health department shall have access for public health interventions related to prescribing trends and controlled substance use. And it then goes on to specify the additional security and de-identification requirements for that data. So it's very important to know where to access this information, because when filling out the data sharing request information, authority is going to be one of the first components needed. So what does the data sharing process look like? So the information that's currently needed to obtain the data involves the local health department submitting a statement of usage to the PMP for review by our legal counsel. The statement of usage has to include the purpose for the data, how that data will be utilized, how it will be de-identified by the board, the estimated frequency of requests. We're hearing approximately 5 patients every quarter, how that data will be received, and then how it will be stored by the department once it's received, and then the information for the primary contact receiving that data. Currently, we require 3 separate forms for this process. There's a data sharing agreement, a business associate agreement known as BAA, and the security and privacy questionnaire, the SPCQ, which have to be drafted and sent for signatures on both parts, both the local health department and the agency, DHS as an agency. And then we need to know what kind of information is needed on the patient history record. These requests have to be submitted on the local health department letterhead via email to our general mailbox. It has to state the authority, as I mentioned before, the section of statute that allows for this data sharing, the purpose, and then the data sharing agreement number for reference. The demographic information for the patient, so we know what data to pull, which would include the name, date of birth, and address. And then the specific data elements that are being requested, as well as the date range for the request and the due date for the request. The data elements that we currently have available that we are sharing through most of our law enforcement requests include the demographic information for the patient, name, date of birth, address. We can provide the drug name and strength that was received during the time period identified, as well as the quantity dispensed, the fill date for that prescription, the prescriber name, and the dispensing pharmacy name and location. I will also add that if additional data elements are needed, that if they are available to us, then can be shared, that would be something that we can discuss for further consideration. And I just like to remind everybody that PMP data is very highly protected. Access is limited to the public health functions identified. Very strong confidentiality protections are built into both the statute and to program policy. So just as a reminder, we need to make sure that the data is only used for the purpose in which has been stated. And finally, I just wanted to make everyone aware that currently the prescription monitoring program has publicly available data dashboards on our website. If you go to ilpmp.com, you don't have, or .org, sorry, you don't have to have, you don't have to be a provider to access the dashboards. This is a part of our public facing page. And we have current information on, at a county level, on multiple provider episodes. For us, that's defined as a patient who is seeing 5 or more prescribers, getting them filled at 5 or more pharmacies during a 6-month period. We also are showing data on high dose opioids, currently defined as 90 MME per day. I will say that with the change in the CDC guidelines that have de-emphasized the dosing thresholds, we are considering whether or not that information is still relevant. But we do realize that high dose opioids still do contribute to increase in overdose deaths. We also recently updated our buprenorphine data, which includes the buprenorphine prescriptions, the number of prescriptions, the number of patients, and the number of providers per county. And then we have some state level dashboards that look at the total opioid patients and prescriptions, again, statewide, not at a county level, prescription stats by drug type. And this was divided into opioids, benzos, and stimulants, as well as some other controlled substances throughout the state. This was really prompted by a request that we had received from an outside entity. And because we had pulled the data, we went ahead and put it on our dashboard to share, just because we felt that it would be relevant for people working in this area. And then some statewide stats for the CDC indicators, which we report as part of our CDC grant. So again, felt that there would be benefit in just sharing this data publicly for stakeholders and anyone working in this area. And it includes the total number of patients throughout the state that have, again, those high dose opioids, multiple provider episodes, as well as a benzo opioid overlap, because we know that that is a risk factor that increases the chance of an opioid overdose. So all of this data is currently available. I know that we've also tried to do some outreach to local health departments to see if there is other data that would be beneficial to them. Obviously, if we can pull this data, create a query to pull data that would be beneficial for one local health department and provide it for all local health departments, it may kind of lower the number of requests that we receive, and that have that data already available for those who need it. So really, that is all I have, and I'll open it up for questions that you guys might have.
I know I had a few questions, but I will open the floor up for anybody else in case they want to ask first. Go ahead, Megan.
Thank you for this. I came across the PMP data dashboard a few years ago when I started, and I'm excited that it's updated.
Yes, it took a while. We did have to finally hire the data analyst to get those going.
Sure. Just a question. It's the total buprenorphine prescriptions is incredibly valuable, like knowing how many folks are being prescribed it. Is there any, maybe just something that may be helpful? It would be interesting to know, not the drug of choice, but the type, like I know opioids, but like if you kind of can divide that out to like illicit opioids versus prescription versus, like I know in our county we're seeing some issues with kratom, and I'm hearing from providers that they're prescribing buprenorphine because of kratom, synthetic kratom use. So that could potentially be an area for future data that would be helpful, at least like for me in my county. That would be interesting to know and helpful to our like outreach work and stuff.
So, sorry, and I have to apologize. I'm trying to turn my video on, and now it's telling me that my integrated camera is not working. So, not sure what that is about. So I do apologize that I'm unable to go back on camera. It's weird. So you're saying, so what is it? Obviously, we don't have information on illicit opioids. Unfortunately, anybody prescribing or dispensing Schedule 1, they don't have very good pharmacy compliance.
Yeah.
So, I was just kind of curious when you say, are you looking for the actual just buprenorphine prescriptions? What, I'm not sure I'm understanding.
Sorry, more the what substances are leading to the buprenorphine prescriptions, I guess. I didn't know if that's even like a data point that they have to kind of chart when they're prescribing buprenorphine, like they're prescribing buprenorphine because of heroin use or because
gotcha.
of, yeah, sorry.
So unfortunately, diagnosis is not one of the, or reason for the diagnosis is not one of the things that are required to be reported as part of the PMP. So we have looked at potentially requiring diagnosis. That would require a statutory change. Unfortunately, our proposal many years ago did not move forward. So we don't actively require diagnosis to be reported. It is now an optional field through the ASAP 5.0 upgrade that we're doing. So pharmacies can report it if they have it. They're not required to, and we don't display it at this time.
Sure.
One of the things I've always felt that a change that I would like to see, a future enhancement of the PMP, is if we are getting that data, that we do display it, because what good is having the data if you don't make it available to the people who need it? Unfortunately, that's kind of a heavier lift than it sounds. So again, future enhancement possibilities, something we could address with grant funding would be to upgrade our system to allow for that. We don't allow for it currently, but we do have the ability to collect that data when it is reported to us.
Cool, thank you.
There's a question. Oh, go ahead, Robert.
Hi. Thank you, Sarah, for sharing this really important resource with the OFRs. I have a question related to timeline. So assuming that we get all of the agreements in place and we submit a request, how long do you think it would take, or how long does it typically take to get that information? And I'm just thinking about the time that we need to give ourselves to prepare for our OFR case review meetings.
Sure. I'm not going to lie. I think that anytime you're trying to enter into a data sharing agreement, it always takes longer than I think that it should or anticipate. I think because we haven't effectively entered into one of these agreements yet. There's always a learning curve as far as what information needs to be provided as part of the data sharing agreement process. But once all of the pieces are in place, it's usually a pretty quick turnaround for signatures. I would say 30 days is reasonable. But again, there's usually some back and forth, just making sure that all of the pieces meet the requirements for the state and as reviewed by our general counsel. I think once we start implementing some of these, the process will be easier and it will go more quickly. As far as pulling the data, once we have an agreement in place, an approved agreement, signed agreement, the PMP can turn the data around fairly quickly. So if we get requests, usually we give ourselves a week to 2 weeks to pull that data and return it. But, as long as it's not a large list of patients, and we have the resources to pull the data, it's usually a pretty quick turnaround. The rate limiting step is getting the data sharing agreement signed.
That's helpful information. Thank you.
There's a question in the chat from Molly Peters. Are we able to pull rural sets demonstrating the per capita rate? We have less than 100,000 in the county, so I'm just wondering if that number is suppressed.
We do suppress on our dashboards. We do suppress less than 10.
That kind of feeds into my question. Obviously, there's possibly some gaps in data being inputted into PMP. So, is there any counties in particular that you would say have less data representative for their county than others?
I could probably get that information for you, but obviously some of those smaller southern counties are going to be our biggest suppressed counties. Or I won't say biggest, that sounds redundant, but we see a majority of our suppressed counties in the southern rural areas.
That makes sense. I also wanted to, just for practical purposes, you said turnaround's about 1 to 2 weeks, so that answered one of my questions. But the other one was when they're pulling or requesting data for specific cases for a case review, can they include like 2 or 3 different patient information within one email, or does it need to be submitted individually?
I think it could all be in one email. Yeah.
That makes it easier. Also, one other question I had. Are prescriber names visible on the data shared? And what safeguards are there to prevent punitive or law enforcement action from Illinois PMP side?
I think that's a great question. So the way I understand it, knowing that this is a new process for us, is that we could share the data with the requester, but it has to be de-identified whenever it's presented or reported on the part of the local health department. No identifying information for the patient or the provider can be shared. But obviously, we see the need that they would need to be able to identify providers, to identify, are there multiple providers? Are patients traveling long distances to see providers, things like that. So there's still benefit in having that information, but it couldn't go into any kind of official report.
It's good to know. Any other questions for Sarah? Okay. Not hearing any, so thank you so much, Sarah. This has been such an informational and really invaluable information share. So thank you so much for your presentation.
Absolutely. And again, I apologize that my camera is not turning on, but if anyone has any specific questions or wants to start this process, like I said, there's an email, we can get the process going. The faster that the local health department provides us with the information they need, the faster we can get it reviewed and turned around on our end. So just keeping that in mind, we are happy to be able to assist in any way we can. I'm a big advocate for sharing PMP data because I feel that what good is the data if you don't get it to the people